Eindhoven, which is a referral center for locally advanced T4 rectal cancer and relapsed rectal cancers. Many thanks.
Ladies and gentlemen, thank you, Mr. Chairman. Thank you for the opportunity to share my vision about T4 rectal cancer with you, and I would like to thank the organizers for having me around to do so. Treatment of T4 rectal cancer is quite a different piece of cake than what we have been discussing now. The pelvis is a very small area, and in 10 by 10 centimeters square, we see that a lot of structures are packed tightly together, and on top of that, the innervation of all these organs is also very intense, as you have heard this morning. So we have also seen this slide already. The surgeon has certain access routes to the pelvis between the fascial spaces, but when we're talking about T4 rectal cancer, and I'm talking about MRI defined T4 rectal cancer, which is a cancer which has progressed beyond these access lines, has invaded into the normal organs and structures. So essentially what we have been used as a guideline to enter the pelvis, the mesorectal fascia, is not anymore the border for the resection, but we have to look beyond that. So as you have also heard, it's very important that the distance between the tumor and the circumferential resection determines the chance of developing a local recurrence. It's all the basis for our TME surgery. And then I was asked to talk about T4 rectal cancer, and these are the type of cancers we see: infiltration into the prostate, in the pelvic sidewall. And then what really hit me was how to avoid excentrative procedures in those patients. You can imagine that, well, we are doing these excentrative procedures in these T4 rectal cancers. There are some publications about larger series which show that it's quite successful, but how to avoid excentrative procedures in these patients is a different question. And you can imagine these are the type of procedures we're planning for these patients, and how to avoid bladder resection, excentrations in these patients. Fortunately, we have a very large database of T4 rectal cancer tumors that have been treated in our hospital, and we looked back into these data, and we could define some measures that maybe can limit the extent of surgery. These are our patients, these are the male patients, T4 rectal cancer patients, and you see that not so many patients did really require total excenteration, but many of them did require some part of an excenteration, either a full excenteration of the bladder or a less excentrative procedure. These are typically male patients, and for the female patients it's the same. So when looking back at the almost 400 patients who with a T4 rectal cancer, approximately half of them had some kind of an excentrative procedure. And so I could try to answer the question, and the other half then, why didn't they have an excentrative procedure while there were MRI-defined T4 rectal cancers invading beyond the rectal fascia? So extended resections, again, we have to remove the sacrum in some of these patients, but as you see, we could avoid that in quite a lot of patients. This is also a procedure which you would like to avoid, because you can imagine that this has a severely impact on the quality of life of these patients. So the primary principle of treating T4 rectal cancer is achieving a radical resection. So without an R0 resection, this patient has a high likelihood of dying of the cancer. It remains a radical resection, so the surgical quality of the procedure remains the most important variable. I will show you a slide. This is an MRI scan, and as I told you, all our T4 rectal cancers are staged with MRI because it's not about the rectum we need extra information, but we need about the surroundings, about the topographical anatomy, and about the response to neoadjuvant treatment in these patients. This is a T4 rectal cancer. It's not very huge, but it's located very close to the pelvic side wall, and it does, in fact, encase the ureter. And even after radiochemotherapy, you see that the tumor has shrunk quite a lot, and the ureter seems to be free of tumor. However, I don't think you would like to do the resection along this plane. So what we did in this patient was do a partial ureterectomy and reinsert the ureter in the bladder. So this is one of the things you can do to avoid a major excentrative procedure, is to do a partial excentrative procedure. So to take away not the whole bladder, but to take just a part of the bladder. This, of course, is a mucinous rectal carcinoma, and you can imagine that this is quite a challenge to do this without an excentrative procedure. And these kind of tumors, the mucinous kind of tumors, they don't regress too much after radiochemotherapy, and without any doubt, it's very difficult to do a partial resection in those patients. So these are typically the patients that still will require major resections. What are the results of this kind of surgery? If you look at the bladder resection in T4 rectal cancer, or partial or total, and then with partial and also a part of the bladder can be addressed, you see that overall the results are quite satisfactory. It is, if you need to take out the bladder, the overall survival of these patients will be really acceptable, which is for T4 rectal cancer in the same range as early non-metastasized rectal cancer. Other organs, of course, which can be taken out are the seminal vesicles and the prostate. Invasion of the prostate is rarely that intense that the complete prostate has to be removed. A partial prostatectomy or removal of seminal vesicles is also a good option. And you can see, if you look at the cases that we have done such a partial resection of the vesicles, or in this case the vesicles, you see the outcome is quite acceptable. Partial prostatectomy is also quite rewarding with regards to overall survival. Then, of course, other problems are invasion of the, in this case, the distal sacrum, but also of the upper sacrum. And you can imagine that even after radiochemotherapy, these kind of tumors will never be amenable for a sacrum-sparing procedure. So once the sacrum is involved, you're most likely to have to remove it. These kind of patients, and I think you will all agree with me, even higher up patients. If you look at the overall results of these kind of procedures, then you see they are also quite rewarding. There was no statistical significance, but however, it seems that the higher the resection is, the more likely that the patient will have recurrence of their disease. And then, of course, in female patients, the uterus is an important structure which can be easily removed and which protects the bladder in most cases for invasion. Because in male patients, it's much easier to invade the bladder. But this is an example of a patient who had indeed invasion of the uterus and also invasion of the bladder. And what's very nice to see, and if you have MRI scans in different directions, you can follow the vessels, you can follow the ureter, so the extent of the resection which is needed can be determined beforehand. And again, the patients who did undergo a hysterectomy because of involvement of tumor did very well when compared to those who did not need a partial or complete exenteration. Again, mucinous tumors are much more difficult to treat because their response to neoadjuvant treatment is not so extended. And if we look, for example, at all the patients who had involvement, this is not about mucinous carcinoma, but all the patients who had involvement of their partial involvement of the vagina, and you can see that all these patients also have a rewarding survival. So overall, what has been published before by other authors is that multivisceral resection can be the answer to cure these patients, but how to avoid it? What I told you, this is absolutely mandatory to achieve an R0 resection, because if you have an R+ resection, then you see that these patients do much worse. You will cure some of them, but in the end, the overall survival is much worse. So I've told you we give these patients neoadjuvant treatment, and sometimes this can lead to a very good response. In fact, most of the patients will respond to neoadjuvant treatment. But the question to how to downscale the operation, this is a patient which has a very nice response, but it still remains quite difficult to define your safe operation planes. So would you be confident to have a close margin in this patient? This is a patient which had a complete response, but do we see it? The problem after T4 rectal cancer is that we do see these excellent responses, but it's not like in a T3 or T2 tumor that the integrity of the bowel is restored, and you can say, okay, I have quite a normal bowel. In these cases, the changes remain. Fibrosis occurs, and it's difficult to say what you can do with this fibrosis. So, however, downstaging is quite important. What you see here is if you achieve downstaging in these patients, the chance of performing a radical resection is much higher. And of course, this is the primary goal of our treatment. Let's say in early rectal cancers, we are learning that if you wait longer, you will have better responses. And I was thinking that this might also be true for advanced rectal cancer, but a little bit to my astonishment, this is not really true. We do see that if we wait longer, then the number of radical, you shouldn't do the operations too early, but much longer doesn't give a clear image. And we couldn't demonstrate that there was a statistical significance if you wait longer than those 6 weeks. We do. In fact, we wait for 12 to 16 weeks before we do the operation. It's not wrong to wait, but it didn't help us as much as I expected. So this is the kind of downstaging you can have with neoadjuvant treatment, and you see that most of the patients will have some downstaging. And you can see this in this slide, 77% have at least downstaging from T4 to T3, but then it drops very, very sharp. We see only downsstaging from T4 to at least T2 or less in only 24% of the patients, and T1 13%, and a complete response we did see in these cases only in 11% of the patients. So downstaging is not the way to go, I think, for these kind of patients. So what was the influence of downstaging on the risk of receiving a multivisceral resection? You can see, while there was quite an influence on achieving a radical resection, still quite a lot of patients, but less than if you're not downstage, did undergo a multivisceral resection. In the end, it is the most important factor to avoid a multivisceral resection in this group of patients. Again, the question, you see, this was one of the examples of complete downstaging. Again, the problem remains the fibrosis and the difficulties for defining that these patients have a complete resection, because I didn't dare to transect through this area, and I took out a part of the bladder as well in this patient, and I did find it was not necessary. So this is one of the difficulties in the management of T4 rectal cancer. As I told you, you can try to avoid a complete multivisceral resection, or you can avoid, and you can do, but you can also do instead a partial resection. And this is more interesting to see, because if you see this downstaging happening, then you see that the need for a complete resection of the bladder or the uterus or the sacrum is much less pronounced. So downstaging is the answer to this question. And again, this was also in a multivariable analysis true. So, of course, how to downstage, and many studies have been, and I think that tomorrow this study the PETAC-6 study will be discussed about using radiochemotherapy with a combined drug. So in this case, it was oxaliplatin, but in the end, the PETAC study did not show that, the PETAC-6 study did not show that there was more downstaging with the addition of oxaliplatin than we would have expected without oxaliplatin. And we participated in the core study, which started in 2003, and we went on using oxaliplatin capecitabine as radiochemotherapy before the results of the randomized studies became available. And we did see that there is intensification of the neoadjuvant treatment does help, but I don't think that this difference between capecitabine only and oxaliplatin capecitabine therapy is that much rewarding that we should continue using oxaliplatin. This is the overall survival, which is split up regarding the type of neoadjuvant treatment we used in these kind of patients. And you do see that the combination of oxaliplatin capecitabine seems to be the best combination, but in the end, this is not a statistical significant difference. The only thing that is different is radiotherapy alone does not work, or at least it does work less good. So this is what we know. The circumferential resection margin is important. This is from the Dutch DME study, but it has been confirmed in various other studies. And there seems to be a gradual difference. So if you have a 0 to 1 millimeter margin, then the chance of a local recurrence is high. And it's a little bit less if it's 1 to 2 millimeter, and again, a little bit less if it's 2 to 5 millimeters. So this seems to be, like in the study from Wiebe I showed you in the beginning, there seems to be a gradual change. Well, in the specific thing we do in the Catharina Hospital in the Netherlands is that if we accept close margins, we would irradiate this close margin during the operation with an intraoperative electron beam boost at the area of risk. This is how it's working. This is in the operating theater. We work here. Then we move the patient to the linear accelerator and give a boost at the area of risk. And is it rewarding to do so? Well, this is the principle of this. You give electrons, so the penetration depth is within the millimeter range, and you can decide on how deep you would like to do this. It's on top of the neoadjuvant treatment. And what we did see, and this is quite promising, is that the same what we did see in the TME study. So this kind of gradual change doesn't happen if you irradiate the area at risk. In fact, if you look at the 0 to 1 millimeter margin, or the 1 millimeter to 2 millimeter margin, you're quite safe, even as safe as all these other margins. So this is, I think, the contribution of intraoperative radiotherapy in T4 rectal cancer, and it may be one of the reasons we could look further into, because we give it as an intraoperative electron boost, but with the new linear accelerators, probably you can also deliver boosts with other means, with IMRT, or maybe with brachytherapy, or whatever new techniques are becoming available. This just tells you that intensification of this treatment can help to achieve more radical margins. So Let me come to my conclusions. There is a downside in the management of T4 rectal cancer. We still do not have a compensation for positive, really, truly positive margins. We still will be needing excentrative procedures, and intensification of the preoperative radiochemotherapy did not bring what we hoped for. And the interval, which is so promising in more early rectal cancer, did not seem to affect our R0 resection rate. However, the promising findings are that close margins may be safe if we intensify the radiotherapy, and close margins means that this influence our treatment. So if we see a patient who responds well to neoadjuvant treatment, and we can define a margin between the tumor and the organs which are threatened by this tumor, then we can accept this close margin. So we do not need to make our planning on the primary MRI scan and the primary presentation of the tumor. So close margins may be safe. And downstaging can convert this complete excentrative procedure to maybe a partial procedure. And as I told you, I believe in intensification of the radiotherapy techniques. In the future, we will see new techniques coming up. And interval does not seem to affect the R0 resection rate in a positive way. However, it didn't also affect it in a negative way. So this interval even can be extended and can be used for, let's say, systemic therapy during the end of the radiotherapy and the surgery. So this is also a clue to a further intensification of the treatment. Thank you very much.